Welcome to the deep dive. Today, we're stepping into the really high-stakes world of emergency surgery. Forget the carefully scheduled operations. We're talking about those critical moments when, split-second decisions and immediate action really mean life or death. We've pulled together some really in-depth materials that shed light on the unique pressures and, frankly, the incredible resourcefulness needed in this, well, vital field.
Absolutely. And what's striking right away is just how different it is from elective surgery. One is, a carefully planned event. The other is a reaction to something totally unpredictable, often chaotic, acute illness or injury. Our goal today is really to get a handle on what it takes to operate when time is just, well, the biggest enemy.
Okay, so let's start there with the environment itself. Our sources paint this picture of immense pressure. What are some of the immediate, really significant challenges these surgeons face?
Well, top of the list, without a doubt, is time. The sources make it crystal clear. Emergency surgeons often have just minutes. Minutes to get a diagnosis, size up the situation, pick the right surgical approach, and get the OR ready.
Just minutes. Wow.
Yeah, and that really compressed timeline, it means they often don't have the chance for that thorough preoperative assessment you normally do.
Mm-hmm.
The kind that's standard in elective cases. And that naturally bumps up the risk of complications.
Right, there's just no time for all the usual tests and checks. And that seems to lead straight into another big hurdle the sources mention: incomplete patient information.
Exactly. Think about patients who arrive unconscious, or maybe they're in severe distress. Crucially, you might not have a detailed medical history, no list of allergies, no idea what medications they're on, no previous test results to look at.
Hmm.
And this lack of information is a major clinical challenge. It forces the team to make really critical decisions based on, well, an incomplete picture of the patient's health.
It sounds like trying to solve a really complex puzzle but missing half the pieces.
That's a good way to put it.
And on top of that, the patients themselves are often incredibly fragile states when they arrive.
Precisely. Our sources describe patients coming in, in shock, where their body isn't getting enough blood flow, or they're struggling to breathe, or losing a lot of blood fast, trying to manage dangerously low blood pressure hypotension and a really fast heart rate,
Hmm.
tachycardia, while dealing with active bleeding and trying to secure their airway. It's an immense task.
Yeah, that sounds overwhelming.
It almost always takes a highly coordinated effort from multiple specialists, and often means heading straight to the ICU afterwards.
So you've got this severely ill patient, you're racing against the clock, you don't have all the background info. What else gets in the way? The sources also mention limits on resources.
That's a really critical point. And it often gets worse because emergencies don't care about 9 to 5 schedules, right?
Right.
Understaffing can be a huge issue at night, on weekends, holidays. You might not have enough surgeons available or anesthesiologists, or even just getting access to a free operating room or specialized equipment, or crucially, blood products when you need them.
Mm.
And in smaller hospitals, maybe more rural ones or places that aren't as well funded, the lack of dedicated trauma teams adds another layer of difficulty. Surgeons often have to, well, improvise.
Improvise during surgery. That sounds incredibly demanding. And then you add the complexity of cases that aren't just one single problem, but maybe multiple injuries.
Exactly. Trauma patients are a prime example. They often come in with injuries affecting, several different organs and body systems all at once. So the surgical team has to figure out, okay, what's going to kill the patient first? Prioritize that. But they also have to think about long-term recovery. This often leads to staged procedures, like something called damage control surgery.
Okay, damage control surgery. How does that work?
Right, so the first operation is all about stopping the immediate threats, controlling major bleeding, preventing contamination from, say, a bowel injury. They might pack the wounds temporarily. Then the patient goes to the ICU for stabilization, let the body recover a bit. Then later, once they're more stable, they go back to the OR for the definitive repairs.
Ah, okay. That makes sense.
And the complexity just skyrockets if you have multiple severe injuries, polytrauma, or if the patient already has significant health problems.
It really is a delicate balancing act. And speaking of potential problems, infection risk seems like it would be much higher in these emergency situations.
Or absolutely, the risk is considerably higher, especially if you're dealing with things like perforated organs, nasty abscesses, or heavily contaminated trauma wounds. Sometimes the patient might even arrive with an existing infection, like sepsis, which is life-threatening itself. And the chances of developing infections after surgery, like peritonitis, that's inflammation inside the abdomen, those chances go up too.
So even with antibiotics and sterile technique,
Right? Even with strict sterile technique and antibiotics, which are crucial, You can't completely eliminate that heightened risk. It's just inherent in the situation.
These are all such high-stakes scenarios. It makes sense that even just communication within the team could be a challenge.
Precisely. I mean,
Yeah.
think about it. The emergency environment is often noisy, chaotic. You've got multidisciplinary teams, people from different specialties, different experience levels, all trying to work together fast. You might have language barriers. The patient might be confused or disoriented.
Yeah.
Any breakdown in communication in that kind of setting can, unfortunately, lead to errors, sometimes with really serious consequences.
And finally, the sources remind us the outcomes themselves can just be unpredictable.
Yes, that's a
Yeah.
tough reality.
Yeah.
Despite everyone's best efforts, the rates of morbidity, that's illness and mortality, death, they do tend to be higher in emergency surgery compared to planned procedures.
Mhm.
Factors like how severe the injury was, how long it took the patient to get help, any underlying health problems they had, it all plays a role.
Mm.
And this inherent uncertainty, it really highlights how carefully you have to manage risk and, importantly, how sensitively you need to communicate with the patient's family.
It truly paints a picture of an incredibly challenging field. Okay, let's shift gears a bit now and talk about how the actual life-saving techniques surgeons use in these critical moments. What are some of the fundamental approaches?
Well, one of the real cornerstones, as our sources highlight, is traditional open surgery. This usually means a laparotomy, making a large incision in the abdomen, or maybe a thoracotomy, an incision into the chest. The key thing is it gives surgeons direct visualization. They can see everything clearly and get full access to the organs inside.
Right. And when is that the go-to method?
Open surgery is still essential for things like massive internal bleeding, penetrating injuries, like stabbings to the abdomen, organ perforations, bowel obstructions. Also, conditions like a ruptured ectopic pregnancy. That's when a pregnancy implants outside the uterus. The big advantage is the direct control it offers. You can explore multiple organs if needed, and it's often easier, especially if the patient is very unstable.
But there are downsides.
Sure, the trade-offs are bigger scars, usually a longer recovery time for the patient, and potentially a higher risk of infection compared to less invasive methods.
Okay. Now, you mentioned damage control surgery earlier. Our sources go into that as a specific strategy. Can you walk us through that again in a bit more detail?
Yeah, damage control surgery, or DCS, is really vital for patients who are just too unstable, too physiologically overwhelmed to handle a long, definitive operation right away. It's a deliberate, staged process. Phase 1, the initial surgery. Focus only on stopping major bleeding and controlling contamination, like from a leaky gut, maybe temporary packing of wounds. That's it. Get out quick. Phase 2, ICU resuscitation. The team works hard to stabilize the patient, correct problems with blood clotting, fix low body temperature, manage severe acidosis, which is too much acid in the blood, really get their physiology back on track.
Right. Give the body a chance.
Exactly. Then phase 3. Once the patient is stable enough, they go back to the OR for the final definitive surgical repairs. It's used a lot in severe trauma with multiple injuries or bad penetrating wounds.
So it's really about tackling the immediate fires first, then letting things cool down before the major reconstruction. What about the minimally invasive options? Laparoscopy, for instance. Does that have a place in emergencies?
It does, yes. Laparoscopic surgery using small incisions, a camera, special tools definitely has a role, but it's generally for patients who are more stable and for specific conditions.
Like what, typically?
Well, the classic example our sources mention is acute appendicitis. That's very commonly done laparoscopically now. Also, some selected cases of perforated ulcers, gallbladder inflammation, cholecystitis, and certain gynecologic emergencies.
And the benefits are?
The potential benefits are significant. Less pain after surgery, often a quicker recovery, smaller scars, and usually a lower risk of infection.
But limitations, too.
Definitely. It's generally not suitable for major trauma, where there might be massive bleeding, or if the patient is hemodynamically unstable, meaning their blood pressure and heart rate are all over the place. Plus, you need the specialized equipment and, importantly, a team trained in those techniques readily available.
Makes sense. And beyond those main surgical approaches, the sources also talked about some interesting non-surgical techniques and also temporary measures.
Absolutely. Things like endovascular and interventional techniques are becoming increasingly important. These are minimally invasive, often using catheters guided through blood vessels. They can be lifesavers for managing internal bleeding or repairing injured blood vessels without big incisions.
Can you give an example?
Sure, embolization is a key one. That's where they inject tiny particles or coils through a catheter to block off a bleeding vessel. It's often used for bleeding in the liver, spleen, or pelvis, or using stents, little mesh tubes to repair damaged arteries or treat ruptured aneurysms.
And the advantage there.
Big advantage is they're much less invasive. They can sometimes be combined with surgery or even used for patients who are just too sick for a major open operation.
Okay. And those temporary measures you mentioned before, like temporary abdominal closure.
Right, those are crucial tools as well. Temporary abdominal closure techniques using things like a vacuum-assisted closure device, sort of like a wound vac, or even a sterile plastic bag called a silo, those are used in damage control surgery.
Mm.
Or sometimes just when there's so much swelling inside the abdomen after a big operation that you physically can't close the skin safely right away.
And things like tourniquets.
Tourniquets, hemostatic dressings, those are vital for controlling severe limb bleeding before the patient even gets to the hospital. Pre-hospital care. And there's also a technique called REBOA. Yeah, stands for resuscitative endovascular balloon occlusion of the aorta. It's pretty amazing, actually. They insert a balloon catheter, usually through an artery in the groin, thread it up into the aorta, the body's main artery, and inflate the balloon.
And that does what?
It temporarily stops blood flow down to the pelvis and legs. It's a way to buy time for patients with massive, life-threatening bleeding deep in the abdomen or pelvis until they can get to the OR for definitive control.
Wow. That's quite an intervention. So with all these different options, open surgery, DCS, laparoscopy, endovascular, temporary measures, how does a surgeon decide what to do in the heat of the moment?
It's a complex decision based on several key things. First and foremost is the patient's stability. Are they crashing? That pushes you towards open or damage control. Then what resources do you actually have available right now? The right equipment, the right staff, the surgeon's own expertise and comfort level with different techniques obviously plays a role. And underpinning it all is time. How quickly do we need to intervene to save this person's life? All those factors get weighed very, very quickly.
It really sounds like a constant process of rapid evaluation and adapting on the fly. Okay, let's focus now on why someone might need emergency surgery. We mentioned acute appendicitis. That seems pretty common.
Yes, acute appendicitis, inflammation of that little appendix pouch, is definitely one of the most frequent reasons for emergency surgery. The classic symptoms are pain, often starting near the belly button, then moving to the lower right side of the abdomen, maybe fever, nausea, vomiting, loss of appetite.
And the surgery is appendectomy.
Right, removing the appendix, an appendectomy, often done laparoscopically now, as we said. The urgency comes from the risk of that inflamed appendix bursting or rupturing. If that happens, it spills infected material into the abdomen, causing peritonitis, which is a very serious, potentially fatal infection.
Okay, got it. Another major reason you mentioned was internal hemorrhage, internal bleeding. What are the key dangers there?
Internal hemorrhage is bleeding happening inside the body. It can be caused by trauma, like a car crash or a ruptured blood vessel, maybe from an aneurysm, or complications from other medical conditions. Signs can be low blood pressure, a really fast pulse, maybe the abdomen swells up, confusion, even passing out.
And surgery depends on the cause.
Exactly. You have to find the source of the bleeding and stop it. That might mean an exploratory laparotomy, opening the abdomen to find the bleeder, or repairing a specific blood vessel, or sometimes even having to remove a badly damaged organ like the spleen. The key is speed. Uncontrolled internal bleeding quickly leads to shock, organ failure, and death if not treated fast.
Very serious. And then there's the whole huge category of trauma surgery itself.
Right. Trauma surgery deals with injuries from accidents, violence, falls, you name it. We usually talk about blunt trauma, like from impacts, versus penetrating trauma, like stabbings or gunshots.
And the injuries can be.
All sorts. Lacerations or tears in the liver or spleen are common. Broken bones, bleeding inside the head, collapsed lungs. The list goes on. The urgency in trauma is usually because these injuries immediately threaten the ABCs, airway, breathing, circulation, or they cause neurological damage, so you have to act fast.
Our sources also briefly listed a few other common emergencies needing surgery. Can you quickly touch on those? Why are they urgent?
Sure. A perforated peptic ulcer, basically a hole in the stomach or duodenum lining, needs immediate surgery to patch the hole and wash out the abdomen to prevent widespread infection. Bowel obstruction, where the intestine is blocked, is urgent because the trapped bowel can lose its blood supply, that's called strangulation, or it can perforate, burst open. Both need surgery quickly. Ectopic pregnancy, where the pregnancy develops outside the uterus, usually in a fallopian tube. That tube can rupture and cause massive internal bleeding. It's a surgical emergency. A strangulated hernia, where part of the intestine gets trapped in a hernia and the blood supply gets cut off, that also needs urgent repair to save the bowel. And acute cholecystitis, sudden, severe gallbladder inflammation, usually from gallstones, often needs emergency gallbladder removal, a cholecystectomy, to prevent complications like rupture or infection spreading.
It really highlights the sheer variety of critical conditions that land people in the OR unexpectedly. Okay, finally, let's just zoom out for a second. Thinking about the bigger picture, how crucial is teamwork in all this? And maybe, what does the future look like?
Teamwork is everything, absolutely fundamental. It's not just the surgeon, it's the whole multidisciplinary team, trauma teams, anesthesiologists, critical care nurses, radiologists, everyone working together, often simultaneously, especially during that initial rapid assessment and stabilization phase.
And after surgery?
Postoperatively, many of these patients need intensive care in the ICU. Meticulous monitoring, infection control, it remains a team effort. As for the future, well, we'll undoubtedly see continued advancements. Even less invasive techniques, more sophisticated endovascular tools, maybe better ways to manage the body's response to severe injury, like controlling inflammation.
But the core skills remain.
Absolutely. The core principles won't change. Speed, precision, adaptability, sound judgment under pressure. Those will always be essential in emergency surgery.
So wrapping up our deep dive today, it's incredibly clear that emergency surgery is this uniquely demanding field. It's defined by those intense time constraints, often working with incomplete information, dealing with critically unstable patients. We've talked about the amazing range of techniques they use, from traditional open surgery to damage control, minimally invasive options, and those critical temporary fixes. And we've covered some of the most common reasons people urgently need these life-saving interventions.
And it really drives home that stark contrast, doesn't it,
Yeah.
between the controlled world of planned surgery and the unpredictable, high-stakes reality of emergencies. The challenges these teams face are just immense. It takes exceptional skill, yes, but also incredible resilience, sharp judgment, and the ability to make critical calls when everything is uncertain.
It definitely leaves you with a real sense of appreciation, maybe even awe, for the adaptability and dedication of these professionals. They're right there on the front lines of life-threatening situations. The responsibility they carry, the impact they have in those critical moments. It's really something profound to think about. Thanks for joining us for this deep dive.